Okay, today we are going to discuss acute leukemia. Acute leukemia, here you have stem cells in the bone marrow, and the stem cells will differentiate into mature cells. Yes. If you have this block for one reason or another, that means stem cells cannot differentiate it into mature cells. So if the stem cells blocks in its early pathway, we call this acute leukemia. If the stem cells blocks in the late pathway, we call this as chronic leukemia. Acute leukemia, stem cells blocking in the stem cells differentiation in the early pathway with acute symptoms. That means the stem cells which will become as immature cells will proliferate in the bone marrow and proliferate and replace normal hematopoietic elements. That means this immature cells, which we call these cells as a blast, will proliferate as an abnormal blast cells and will lead to damage of the 3 bone marrow elements. So this will lead to the decrease in the number of platelets, so the patient presented with bleeding, and decrease in the number of red blood cells, patient presented with anemia, and decrease in the number of mature white blood cells, so this is decreased, so the patient presented with fever and infection. Okay, but in the blood film, we'll see blast more than 20%, plus white blood cell, you will see increase in the number of white blood cells, but this kind of white blood cells, we call it immature white blood cells, not mature one. Okay, according to the blast cells, if the blast cells, now you will divide anemia according to the blast cells. If the blast cells contain or rods we call this as myeloblast. If the blast cells stain PAS positive and TDT positive, we call this as lymphoblast. Okay, so what are these? Rods are intracytoplasmic inclusion body in the cytoplasm of myeloblasts. So this is basically the rods. Okay, this is the myeloblasts, bilobed or folded large nucleus, and this is the rods with structure intracytoplasmic eosinophilic or azurophilic granules. We call this rods. Usually rod present in M1, 2, 3, or could be present in any kind of myeloblast. This is basically AML. While the marker for lymphoblast is TDT, when you will see TDT, that means immature lymphoblast. Okay, that means immature lymphoblast. TDT actually is the marker responsible for adding a nucleotide to specific region in antibody responsible for antibody diversity. We will talk about this in immunity. So what else, or what other differentiation of lymphoblast, which we call it as ALL and AML? This is usually occur in children until the age of 14, while AML occur later from the age of 15 until the age of 59. So further division of lymphoblast, we can divide lymphoblast according to the type of the cells. If the B cells affected, we call this pre-B cells or T cells. So what are the differentiation between the two? Pre-B cells, usually from the name it is B cells, that means CD19, 20 positive, also CD10 positive, which are good prognosis. This is pre-T cells, that means CD3, 4, 5 positive. CD10, this is CD10 negative, which is CALA gene. How about the clinical features? Usually the clinical features for pre-T cells is presented as mediastinal mass in children, while this usually this is less presented with mediastinal mass. This is usually presented with MITs like CNS manifestations or testicular metastasis. How about the mediastinal mass? Usually the patient, how do you know the patient presented with mediastinal mass? If mass is large, usually become compressed trachea, and if the trachea become compressed, so the patient presented with stridor, or maybe esophagus also become compressed, so the patient usually presented with dysphagia. So when you will see a child presented with fever, nosebleed, and white blood cells count increase, and the clinical presentation is stridor or dysphagia, put in your mind it could be mediastinal mass, that means pre-T cells. Trachea or esophagus usually compressed, or could be presented with superior vena cava syndrome due to the compression of internal jugular vein. Usually this patient syndrome, this patient presented with puffiness of the face and engorgement of the upper chest vein, of the engorgement of the veins in the upper chest and the neck. So again, acute lymphoblastic leukemias are really so important. We can differentiate it into the B cells, usually CD19 and 20, pre-T cells, which are low number of CD3, 3, 4, 5. This is presented with mediastinal mass in case of pre-T cells, while in case of pre-B cells, usually presented as less presented with mediastinal mass and usually presented with MITs, CNS, and testicular. Mediastinal mass, how do you know that patient presented with mediastinal mass? Usually superior vena cava syndrome, trachea, esophagus, which is basically stridor and dysphagia. This is acute lymphoblastic leukemia in children until the age of 14, while AML after the age from 15 to 59. What other types of AML could be important to know? You need to know M3, which is ABL, acute promyelocytic leukemia. Usually this is presented with DIC and a abnormal translocation between chromosome 15 and 17. Other type of AML, we will talk about M3 in detail later. Other type of AML, there is M5, usually presented with gum infiltrations. We call this acute monocytic leukemia.